So the first question is, when you're really happy with something, why do you really want to cover it up with a collar or not is the question. Because we've got such we got such beautiful coral stems. Does it really make a difference? Do we really have to think about something new is the question. I skipped through the first slide because I see some ladies here, so I didn't want to. So why the discussion? Why did this discussion even start? So collar stems have been used by most surgeons without much issue over the decades. We ourselves have been using it. Very good implant designs from all the companies, not just DePuy, and good long-term results as well. So they've got very good integration. So why are we even talking about this now suddenly? It's over the last few months, a couple of years, I think this discussion has started. So why did the discourse start again? So first of all, you can think about the recent advances in THR. One is new surgical approaches like the direct anterior, and these lead to earlier mobilizations. Then you have bone quality, longer lifespans of the patients, older patients undergoing THR with osteoporotic bones. Then now there's a whole discourse about the same day discharges and early mobilization, heavy duty activities. They're not just walking around now, you have people who are jumping, running, and within like a month of surgery as well. So these are all things which can actually lead to maybe subsidence of the stem. There is a thought process behind this. So some of the disadvantages of collared stems, the studies which I've gone through in the last week since I was giving this topic, some of them have shown up to 10% rate of subsidence of the collarless stem, even up to 3 mm at 1 year. So what you've put it in, and then after a year you see that it's really come down. Now this can be because of some micromotion in the initial fixation period leading to fibrous fixation, so not a proper biological fixation. So the subsidence may lead to dislocations, very rare, but more importantly and more problematic are the periprosthetic fractures which can happen in the early and late post-op period. So this is from a paper which I saw where you see that this is the initial intraoperative photo, and later it subsided and caused a fracture. And I think this talk which was given to me a week back was a bad omen for me, Diwakar, because the reason is the day I got the talk, I got this patient in my OP. Literally the same day. We had operated on this patient 3 weeks back, and he came the day I got the talk with this X-ray. So he's in the OP, he's still in the ward. We have to plan the surgery next. So it has subsided, as you can see, here it was at the shoulder, and that has come down, and so we don't know whether he had a fall or not, but he says he didn't. So why use a collar? So how does the collar actually help? Yes, sir.
This collar will not protect you for this particular fracture.
Right.
Two types of proximal fracture. You have the Carcard crack, and then you have this large middle fragment with lesser trabanda as its center. That fracture, the collar will not protect you.
Right. So even this one?
Yeah.
Because this is from the paper which I got, this particular picture. Yeah. So I'm not sure. And so why use a collar at all? So all the papers that I went through, these are the advantages that they've mentioned. It improves the chance of the stem staying in exactly the same position as it was implanted in. So this avoids micromotion, avoids subsidence in the long run, and in turn leads to reduces the chance of limb length discrepancy and periprosthetic fractures, increases the chance of biological fixation, and all this is because of increased rotational stability. So just go through a couple of papers that I went through. This is in the Journal of Arthroplasty, and they studied 59,000 hips in the Australian Joint Registry, and this is what they found. The collared stems are the green line and the collarless stems are the blue line, and this is long-term follow-up. Okay, so there's like years since procedure, even going up to like 10-15 years. And they found two findings. The larger collarless stems had a higher chance of subsidence and periprosthetic fractures than the smaller sizes, and that the collared stems had significantly lower long-term subsidence and revision rate due to periprosthetic fracture. So what they concluded was use collared stems, especially if you're using larger sizes for the femur. Then this another study in the SICOT journal. This is systematic review of all the papers, and they showed both collarless and collared stems having excellent long-term results. But again, they also showed that collared stems had lower subsidence and periprosthetic fracture rates. Another paper again, Arthroplasty Today. What they did was they studied 3 finite element models. There is a collar touching the calcar, okay, and then a collar not touching the calcar with 1 mm gap, and a collarless stem. So they checked the micromotion at the stem bone interface for all these 3 models, and they checked in 2 types of activities. One is in flat walking and one is in stair climbing. So what they concluded was the micromotion of collarless and gap collared is comparable, and micromotion for a collared stem was significantly less. So what they're trying to say over here is it's very important that you don't just put in a collar, it has to actually seat on that neck cut. If you have that 1 mm gap or 2 mm gap, it's actually still going to subside, and that the micromotion is not actually reduced. But if you have a stem which is properly sitting on the neck cut, then you will have a reduced micromotion. Another paper here, Sahil had helped me in this paper, thank you. So again, 2024 paper from the HSS group. They also showed that collared stems show significantly lower periprosthetic fractures and reoperation rates than collarless stems. So when do we use a collar stem? Do we need to use it in every single patient? Today Vijay sir was also mentioning. So LLE patients with osteoporosis, DOR C type femurs, so probably may not really help much in a DOR A or even a DOR B, but DOR C type femurs definitely, when you have a higher risk of subsidence, it will help. And in case of a calcar crack intraoperatively, as sir was mentioning, be ready to change to a collared stem. So you should keep it ready in your armamentarium in case you have such an incident. Then if you have a crack, you put in the collared stem, you know that you're not going to have an issue later on. Thank you.